Okay, so here we are continuing on with our talk about shock. This presentation mainly focuses on different types of shock. We've already covered septic shock, and we're going to go forward now and talk about some of the other types of shock. You've seen this slide before, and we talked about one type of distributive shock, which is septic shock. But we also mentioned in the previous presentation that there are two other types of distributive shock, and we are going to cover them now. Remember, three types of distributive shock are septic shock, anaphylactic, and neurogenic shock. We will also talk about in this presentation hypovolemic shock. This is a very common one as well. And then we'll also mention cardiogenic shock. Okay, we're going to begin with our first type of distributive shock, and this is going to, in this presentation, is anaphylactic shock. And you probably are familiar with part of this because we all know about allergic reactions. But anaphylactic shock is an acute allergic reaction. It is life-threatening, and many different things can trigger anaphylactic reaction, including insect bites, bee stings, various medications. That's why we always ask our patients if they're allergic to any medications, because we certainly wouldn't want to give them one, and that would put them into a life-threatening situation. And the same thing with contrast media. We always ask if they're allergic to shellfish, because there can be some cross reaction in that case with contrast media and dyes. So that's things that we always monitor for in the hospital to prevent this type of reaction. You can have an anaphylactic shock result from a blood transfusion, especially when we talk about those major ABO incompatibility reactions. And even against anesthesia and various foods and vaccines, it is potentially possible to have an anaphylactic reaction, and that can lead to shock. Okay, so let's talk about what characterizes anaphylactic shock. It's the same thing because it falls under distributive shock. It's the same thing that characterizes our septic shock. And I want you to commit that to memory so that you realize if it's a distributive shock, it's characterized by massive, widespread vasodilation of the blood vessels. And what accompanies that is increased capillary permeability. Remember that leaky endothelium that we saw in the previous picture. Okay. Now, anaphylactic shock does result in respiratory failure and circulatory failure. Okay, so it's both of those systems where we see a failure. Because circulatory failure, of course, is circulatory collapse, and that is shock state. But we can also result in respiratory failure as well. Anaphylactic shock is the result of widespread hypersensitivity. The pathophysiology we've discussed before, that widespread vasodilation. So we have the pooling of the blood, and although we have a limited volume of blood, when we have massive widespread vasodilation, we have more of the blood out in the periphery, okay, than is returning to the right side of the heart. We have this relative hypovolemia, and we have altered cellular metabolism. In other words, if the cells are not being perfused, are not receiving oxygen, on the cellular level, respiration changes. Okay, it changes from an aerobic to an anaerobic respiration. And what is the end product of anaerobic respiration? If you remember back, it is lactate or lactic acid. So there is a change in cellular metabolism with all of these shock states. when there is lack of perfusion to the tissues, you're going to have the buildup of lactic acid. Anaphylactic shock results with a subsequent exposure to the antigen. So whatever the antigen was, whether it was a medication or a food or a bee sting, this occurs on the second, at least it has to be the second exposure or a subsequent exposure to that antigen. Okay? And the body responds by releasing histamine. Histamine is found in the basophils of the body. The basophils, remember, are a type of white blood cell. And that histamine causes, in this case, anaphylactic shock is the result, results in increased capillary permeability. So with anaphylactic shock, there is a profound hypotension and vascular collapse. Okay, it's important that you realize that the treatment for this is to administer epinephrine. Yes, I'm very concerned when I look at this patient here. It happens to be a pediatric patient, but of course we have adults as well. It's just easier to find pictures for me with children who are experiencing anaphylaxis. So you notice that there's a lot of swelling around the mouth and in the oral cavity. And so that is a potential problem that could develop, because as the swelling occurs in that region, we see an occlusion of the airway. So inflammation and edema around the airway is potentially very, can be life-threatening. Okay, but the treatment is not to put in a mechanical and intubate this patient for mechanical ventilation. That's not the treatment. That's not what we do. They don't come to the ER and we immediately intubate them. On the contrary, we give them epinephrine, and hopefully that will stem the inflammation and swelling. It doesn't always work, okay? So anaphylactic shock is anaphylaxis with relative hypovolemia and is a severe allergic disorder in which cardiac output and the mean arterial pressure fall rapidly and drastically due to that relative hypovolemia. So as soon as an antigen to which the patient is sensitive has entered the blood, the antigen-antibody reaction triggers the release of histamine from basophilic cells in the blood and mast cells in the tissues. I failed to mention that earlier. And that histamine dilates the arterioles and most peripheral vessels. This results in a falling arterial pressure and increased capillary permeability with rapid loss of plasma water into the interstitial fluid. Now, if you return to the slide where we had the different classifications of shock, you'll see that we are now moving on to another type of shock, and that is the intravascular volume. This is hypovolemic shock, but it's also known as allergemic or hematogenic shock. The essential feature of all forms of hypovolemic shock is loss of fluid from the circulating blood volume, so that adequate circulation to all parts of the body cannot be maintained. So in this type of shock, there is not a relative loss of volume because of leaking endothelium, but instead we have an actual loss of volume. Therefore, we have a decrease in preload, we have a decrease in cardiac output, we have a decrease in tissue perfusion. There is not widespread vasodilation, as we saw with the distributive shock. There is no decrease in the pumping ability of the heart muscle itself. It is simply a loss of volume. Fluid loss can be whole blood. Certainly when we are bleeding or hemorrhaging, there is loss of fluid. but we can also have loss of plasma and the water component in our body, leading to dehydration. So those are the two primary causes, although there are others, but the two big causes of hypovolemic shock are bleeding or hemorrhaging and dehydration. This slide reviews some of those terms we've studied previously in our cardiac unit in perfusion. So I'll just briefly follow through so you can see what occurs with hypovolemic shock. And I'll use the example of hemorrhagic shock, which is the #1 cause of hypovolemic shock. In hemorrhagic shock, there is, where in cases of hemorrhagic shock where there is internal or external hemorrhage due to trauma, there's a loss of whole blood, including the red blood cells. The diminished blood volume causes a markedly lessened cardiac output and reduced peripheral circulation. This results in reduction of oxygen transported to the tissues, and the term we use to describe that is hypoxia. Reduction of perfusion, the circulation of blood within an organ, and reduction of waste products transported away from the tissue cells all occur. Under these conditions, body cells are not able to carry on their normal functions. They can only carry on their normal functions for a short period of time. So if you follow the arrows on this slide, from a decreased blood pressure, which is shock, right, to a decreased blood pressure means that there is decreased cardiac output. And the reason for the decreased cardiac output is because of the decrease in stroke volume as we follow the arrows down. Remember that stroke volume is influenced by preload, contractility, and afterload. When you have a decreased stroke volume, you have a decrease in preload. So this is how hemorrhage affects blood pressures. Okay, and it decreases the preload, it decreases the cardiac output, and it decreases blood pressures. Okay. While I've already stressed the two most important causes of hypovolemic shock, be aware that there are other causes as well. I'm not going to go through all of them. I'm happy if you can remember the two most important causes. One is bleeding or hemorrhage. The other is dehydration. How you get to dehydration? There's lots of them found down here. For example, profound diaphoresis. Okay. So you can lose lots of fluids through profound diaphoresis. But here's another one which may not have crossed your mind. And that's something we have to think about in the hospital, because excessive use of diuretics can actually put our patient into a hypovolemic shock. If they are losing so much through the diuresis process, so much fluids that they actually have a decrease in circulating volume, then they can go into a hypovolemic shock. Even for profound GI losses of fluid. And then in this course later, we're going to talk about burns and major burns. Those can also lead to hypovolemic shock. And you've already studied DKA, and you know a feature of DKA is severe dehydration. That's the main thing. Even before we work on glucose, we work on hydrating these people. So DKA also can lead to hypovolemic shock. And in this, we do talk about closed head injuries, and that is because a lot of closed head injuries do lead to diabetes insipidus, which is a metabolic disorder in which they void large volumes of diluted urine. And so again, there are many ways in which patients can develop a hypovolemic shock. And that is why we say it's so important to apply pressure to stop bleeding, because bleeding is the #1 cause, and we want to prevent them from going into a hypovolemic shock. Okay, I'm not going to talk about burn shock here. We'll go on to the next slide. So we realize that bleeding can be internal or external. In this picture, we're looking at internal hemorrhage that can occur, for example, in a motor vehicle accident. We see a laceration to the liver and in other areas within this picture, including the pancreas back there. And to the intestinal mucosa is bruised and bleeding as well. Okay, so realize that there are several potential spaces inside the body that can accommodate large amounts of blood that may accumulate following an injury. We call that third spacing. Okay, but third spacing is a term that refers to fluids in any space where it doesn't belong, where it shouldn't be. Okay. If there's chest trauma, the pleural space is a potential space for the accumulation of large amounts of blood. If it's abdominal trauma, of course, we have the abdominal cavity, as we see in this picture. If it's a pelvic fracture, and we have the retroperitoneal region, pelvic fractures can be an important source of major hemorrhage in victims of blunt trauma. Okay, so how are we going to know if somebody is bleeding internally? That's something that you have got to be able to recognize. And one of the main ways we can determine that is through our vital signs. And so you will be tested on this, and you must understand this. When somebody is bleeding, what are the changes that occur in their vital signs? You hope to see an increase, a normal increase in heart rate, an increase in the breathing rate, and a decrease in their blood pressure, right? That's normal physiology. That's what occurs. So you need to be able to follow that line of thought and connect the pieces. And certainly, of course, there's physical assessment. Sometimes you can see bleeding through ecchymosis, and especially if they're bleeding into the retroperitoneal area, you need to look on the back of the patient, because if they're laying flat in bed, the bruising is going to occur on their back, and you won't see it on their abdomen. So we have to look for other signs and symptoms of bleeding, especially carefully when it's internal bleeding. Especially, I'll come back to that pelvic fracture. That's one of those major structures. There's so many major structures housed by the bony pelvis, including the viscera, major blood vessels. So when there is a disruption or fracture of this protective ring, this bony ring, the pelvis, it can be catastrophic. And we are aware of that in the ER. So we want to know that a person with pelvic fractures is at risk of developing internal hemorrhage and, of course, hypovolemic shock. So we have to monitor them very closely. Mortality rates can range as high as 55%, depending on the severity of the fracture and associated injuries. Mortality due to pelvic fracture with hemorrhage has historically approached 25 to 40%. Hypovolemic shock usually results from acute blood loss, about 1/5 of the total blood volume. Such massive blood loss may result from internal hemorrhage, GI bleeding, or external hemorrhage, accidental or surgical trauma, or from any condition that reduces circulating intravascular plasma volume or other body fluids, even such as severe burns. Other underlying causes of hypovolemic shock include intestinal obstruction, peritonitis, acute pancreatitis, ascites, and dehydration from excessive perspiration, severe diarrhea, or protracted vomiting. We already mentioned diabetes insipidus, excessive diuresis, or inadequate fluid intake. So we need to identify those patients that are at risk that have been assigned to us by understanding this pathophysiology of shock. This picture, this diagram, shows an accidental trauma, and so we can see all the concern here regarding bleeding. And so we just want to mention that if there is an impaled object, whatever it is, if there's an object in this patient, we are not to pull it out because it's basically acting as a tamponade or pressure and preventing bleeding. So the object should be left alone. Do not pull it out. We also need to be reminded not to replace protruding organs. Okay, that is something we don't do. And what's best to do is to prevent further contamination by covering open wounds with any type of available material to prevent the falling of debris inside and contaminating it worse than it already is. What you can do is to immobilize the patient and keep the patient quiet. Okay. So here we will review the amount of blood loss that can lead to hypovolemic shock. We consider a significant blood loss to be 750 to 1300 mLs. Okay, so if you want to visualize that, think about a liter bag of normal saline. Something in that range is considered significant and could lead to hypovolemic shock. There are many things that occur in a hospital that can result in this much blood loss. And certainly there is trauma, especially surgical trauma in the hospital, and trauma from accidental trauma for patients that come through the ER especially. And then we have esophageal varices. I believe you've all learned about that. And when esophageal varices rupture, we have massive blood loss through the mouth especially. Okay, and they can lose a significant amount of blood during that episode. And it can be life-threatening, absolutely. And certainly during deliveries, the birth of children, there is lots of blood loss, and sometimes they cannot even control the blood loss, and they search frantically to try to stop the blood loss during deliveries to prevent hypovolemic shock and the demise of the mother. Now, when patients go to surgery, they come back and they always report the estimated blood loss to the receiving nurse. Okay, take note of that. The EBL stands for estimated blood loss. We need to take note of that so we know how much blood did our patient lose during surgery. Okay, or if they had to receive units of blood during surgery, we need to be aware of that. And also disseminated intravascular coagulation, when the patient consumes all of their clotting factors and begin to bleed and bleed and bleed. This can lead to hypovolemic shock. Here's an example of impalement in the left chest. I like to, spice up my lectures, and that's why I like to tell this story. In this picture, the patient lost control of his SUV and went off the road. The top rail of a chain link fence went through the vent window on his truck, through his lateral chest wall, through the seat, through the back seat, and through the floor of the Jeep. It's amazing, at no time did he lose consciousness. And he really only complained of being slightly short of breath. But the paramedics arrived and they started IV fluids during the extrication. That means his removal from the vehicle. They started IV fluids. Isn't that a great idea? That's a great intervention. It's life-saving because this person is going to be at risk of hypovolemic shock. Well, in this particular case, the patient could not be removed from the seat because we cannot, well, anyway, we're not supposed to remove that impaled object. So in this case, the patient and the seat were removed from his vehicle as a unit. The patient underwent immediate surgery, and the good news, he recovered fully from this episode. So we will remove the object, but under a controlled surgical environment. Okay, so make sure we can control the bleeding and that the patient does not go into hypovolemic shock. Okay, this slide talks about burns as major burns as an example of hypovolemic shock. And we will cover this in more detail when we talk about burns, but I will address it briefly here. And sometimes hypovolemic shock, when it's related to major burns, is called burn shock. In burn shock, there is a progressive increase in the hematocrit and red blood cell count. This increase is due to hemoconcentration from the loss of the plasma fraction of the blood into and through the burn area. Okay, so the larger the burn, the more major the burn, the greater the fluid shifts that occur. And in major burns and the loss of skin, there is a rapid shift of fluids from the intravascular space to the interstitial space into the tissues. There's this massive fluid shift that occurs with major burns. And that loss of the liquid portion of the blood or plasma causes an increase in viscosity of the blood. It becomes very thick. Now remember, that is going to increase systemic vascular resistance. It's really hard to push around this thick, viscous blood. And so this leads to an increase in systemic vascular resistance and consequently a decrease in tissue perfusion. So we have a little bit of a different scenario here with burns because you're losing the liquid portion of the blood or the plasma fraction of the blood. And when you do that, instead of seeing a loss in H and H, remember hemoglobin and hematocrit always go together. You need to report them together. But when the hemoglobin and hematocrit in a hypovolemic shock where a patient is bleeding, you know the H and H decreases. But that is not the case with burns because of what they're losing, the liquid portion. The H and H actually increase due to that hemoconcentration. And then we want to talk about hypovolemic shock in terms of GI losses. We've already done that, so this is sort of repetitious here, but it is important to remember. Because if you have, for example, a stem of a question, hold on, I'm just trying to situate this. If you have a stem of a question that says the patient has been vomiting for the last 4 days, that should trigger a thought in your mind. Could that be excessive GI losses? Well, yes. And so it's going to lead you down the direction of this patient is at risk of hypovolemic shock. So make sure you can make those connections so that you can arrive at the correct answer. And as always, the infants and the elderly are even at higher risk of hypovolemic shock related to GI losses. Okay, you've already studied parts of pediatrics, and you know how sensitive infants are to dehydration. So they're always at greater risk of hypovolemic shock because their bodies cannot compensate as well for those losses in fluid volumes. Now we're moving on from hypovolemic shock to the next type of shock we're going to talk about is cardiogenic shock. It is also known as pump failure. Okay? With cardiogenic shock, the heart can no longer pump blood forward, and this leads to decreases in cardiac output. That may sound familiar to you. Doesn't that sound a lot like heart failure? Well, it is heart failure, but it's worse than heart failure. Okay? I don't just have a weakened heart pump or left ventricle. Now I have a heart that has failed to pump blood forward. Okay? Let me remind you that cardiogenic shock is not a distributive shock. There is no association with a relative or actual decrease in volume. Okay, there is no widespread vasodilation that causes increase in vascular space or pooling of fluids outside of the vasculature. Okay, that's not it. It doesn't go back to that. It is simply failure of the heart to pump. A major cause is a heart attack. We've talked about heart attacks, MIs, acute MIs, being the result of an occlusion in a coronary artery. That also leads tissue distal to the occlusion to become ischemic and necrotic. If you have a massive MI and there is significant left ventricular damage, over 45% of the heart muscle is damaged by ischemia or infarction, then that patient can go into a cardiogenic shock and have pump failure. The compromised pumping action of the heart, usually a result of a heart attack, myocardial infarction, is what characterizes cardiogenic shock. It is a state in which a weakened heart isn't able to pump enough blood to meet the body's needs. It is a medical emergency, and it is fatal if not treated right away. The most common cause of cardiogenic shock is damage to the heart muscle from a severe or massive heart attack. Now, fortunately, not everyone who has a heart attack develops cardiogenic shock. In fact, less than 10% of people who have heart attacks develop it. But when cardiogenic shock does occur, it's very dangerous. For people who die from a heart attack in a hospital, cardiogenic shock is the most common cause. So certainly the amount of myocardial damage determines the severity and progression of shock in these individuals. There is a significant decrease in cardiac output, which follows with a significant decrease in the mean arterial pressure. And then you cannot perfuse the body. You cannot meet the body's needs. Now, there are other causes of cardiogenic shock, but as always, I want you to remember the top reasons for these conditions, the ones that occur most commonly, and we already talked about acute MIs, but there are other causes of cardiogenic shock. How about this one? Dysrhythmias, the unit that we've just finished talking about. So certainly dysrhythmias, and in this picture we have a EKG strip showing torsades de pointes, and that is a type of ventricular tachycardia. That arrhythmia can lead to cardiogenic shock. We have pump failure. It's not able to generate sufficient cardiac output to perfuse the body. And then we have heart failure. Remember, it's a progressive disease. Heart failure is progressive. It gets worse and worse. So at the end stage, stage 4 or stage D, depending which classification system you use, end stage heart failure, those people who are going home with usually IV infusions of Natricor, Primacor, to improve the contractility of their heart. These end-stage people are at risk of cardiogenic shock. And here you can read through all the various other things. Some of them we've talked about in the past that can all result in structural changes that make the heart pump unable to move blood forward, leading to cardiogenic shock. This is a really nice slide that shows you the pathophysiology of cardiogenic shock. It truly is a vicious circle of poor coronary perfusion. So let's review some of these topics here. Cardiogenic shock is defined as sustained hypotension with tissue hypoperfusion in spite of adequate left ventricular filling pressure. Okay, the left ventricle fills with blood. That's not the problem, but the problem is the heart pump itself fails. Cardiogenic shock complicates 5 to 10% of all acute myocardial infarctions and has a mortality rate approaching 80%. A vicious circle of poor coronary perfusion with worsening cardiac output occurs. It is essential to break the vicious circle with mechanical augmentation and reversal of the underlying insult. Okay, so follow through there. Remember, when the pump fails, and this picture is showing you as a result of an acute MI, an infarction, cardiac output is going to decrease. And that means that the heart muscle itself, remember it feeds itself first through the sinus of Valsalva, there is reduced coronary perfusion. And when the body is not getting enough oxygen, what is the normal response of the heart? The sympathetic nervous system says, heart, beat faster, okay? Because we're not getting enough oxygen. But the heart is failing. The pump is failing. And now it's like whipping a, I wouldn't say dead horse, but might be getting there. We've got a heart that is so weak, and now it's not getting oxygen to the tissues. The tissues need more oxygen, and so it says, our body says, beat faster. Well, the heart isn't even getting enough perfusion of its own to beat faster. So this is why this is a very vicious circle, and it can lead to the demise of the patient. Now, looking at the other end of the slide, we see tissue perfusion decrease to the body. And because of that, at the cellular level, cellular respiration changes from aerobic to anaerobic respiration, leading to the buildup of lactic acid. So if I had to ask you, what state are we talking about? Well, if I ask you, what is the acid-base status of a person who's in shock, you should think about metabolic. It's not respiratory, it's metabolic, as we have the buildup of lactic acid in the tissues. Metabolic acidosis is the state, the acid-base status of a patient in shock. Okay, so I think we're going to proceed from here to the next PowerPoint and talk about the various stages of shock that a patient goes through, as well as how we can treat them.